Hello everyone and welcome to Rare à l'écoute, the podcast channel dedicated to rare diseases. Today we continue to explore Cushing syndrome, and to talk about it we are pleased to welcome Professor Rosario Pivonello. Professor Pivonello, good morning.
Good morning.
Professor Pivonello, you are Professor of Medicine, specialized in endocrinology at the Federico II University of Naples in Italy, and you are also a private practice endocrinologist in Naples. You are a member of the Italian Society of Endocrinology, and with numerous national and international publications, you are recognized as one of the international experts in the field of endocrinology, and in particular in pituitary and Cushing syndrome. Professor Pivonello, today we would like to address the multidisciplinary approach of the treatment of Cushing syndrome. And regarding your experience of taking care of patients with this condition, how important is the coordination between different physicians?
Well, the multidisciplinarity is actually an essential element in the management of Cushing syndrome, and indeed it's important throughout the entire clinical process, coming from the diagnosis to treatment and even to the follow-up. As you may know, Cushing syndrome may have different causes, including pituitary tumors, benign and malignant adrenal lesions, or extrapituitary tumors. Therefore, considering this heterogeneity in the etiologies of Cushing syndrome, endocrinologists are constantly requiring to cooperate, so to have also a coordination with different medical specialists in order to provide the best care and also to fasten up both the diagnostic and therapeutic processes. Indeed, many clinical centers, including our centers, organize dedicated periodical meetings for the evaluation of single cases with Cushing syndrome. And these meetings are usually named pituitary boards or Cushing syndrome boards, in which at least 4 different specialists from different medical or surgical areas are involved in the management of each case and may offer the specific expertise and knowledge in the field. Of course, it has to be taken in mind that a multidisciplinary approach does not imply that the endocrinologist has a lower importance in the management of Cushing syndrome. Conversely, endocrinologists represent the main actor in each board they are involved in for Cushing syndrome, as they have to merge each specialist's suggestions and opinions into a single clinical decision. So in an omnicomprehensive view, which is also tailored on the needs of each specific patient.
And more specifically, what are the specialists usually involved in the treatment of patients with Cushing syndrome?
Well, many different specialists are usually involved in the treatment of patients with Cushing syndrome. This is also variable in the different clinical steps, as new or different needs usually raise up during the disease course. As the first step in every disease management is usually represented by diagnosis, the morphological identification, for instance, of the source of the excessive cortisol levels is required to provide the best therapeutic approach and the best therapeutic option for patients. Therefore, in these cases, the specialist may be the radiologist, for instance, or the nuclear medicine physicians, which are usually involved in this phase, and in particular the neuroradiologist with a specific training on the pituitary and cellular region, because Cushing disease is caused by generally very small or sometimes invisible pituitary tumors, therefore representing a diagnostic challenge for many radiologists. So we need a very expert in pituitary tumors, for instance. Then once diagnosis, Cushing syndrome requires a prompt treatment, and surgery represents the first-line treatment at the moment for every form of Cushing syndrome. Therefore, neurosurgeons, for instance, in case of Cushing disease, or general and oncological surgeons in case of the other different forms of Cushing syndrome, are an active part of the therapeutic process, also providing their opinion in terms of possible adjuvant or neoadjuvant therapies according to the potential surgical success. Nevertheless, in some patients, surgery can be not feasible, as you may know. So other treatment modalities, including radiotherapy, and in case of malignancies, also chemotherapy should be considered, requiring therefore an involvement of other specific medical specialists, for instance, radiotherapists and oncologists. finally, it should be not forgotten that Cushing syndrome is associated with many comorbidities, and these comorbidities require a specific medical specialist often to provide the best possible care. For instance, we need a cardiologist for the best treatment of hypertension and cardiovascular diseases associated with the disease, or we can need psychiatrists, psychologists, or neurologists for the neurocognitive and psychiatric diseases, or physiatrics on physiotherapists for the muscle dystrophy, gynecologists or andrologists for the sexual and fertility issues, so also associated with the disease, and not less important, the immunologist for the prevention of the infections disease or the management of autoimmune disease. These are also commonly required in the long-term management of patients with Cushing syndrome. And it's important to say that these physicians are important not only during the active disease, when we are involved in the diagnosis and the first treatment of the disease, but also after the remission phase of the disease, because many of these comorbidities may partially or totally persist in these patients even after the cure of the disease.
And Professor Pivonello, patients with Cushing syndrome are often seen by their general practitioner first. What are the role of the GPs in the management of these patients?
Well, the general practitioners are the first healthcare providers to be approached by the patients, so they represent the first line in terms of patients management, and therefore the general practitioners has really a major role, which is actually the role of recognizing the patients with a clear suspicion of hypercortisolism or Cushing syndrome in order to address them to the endocrinologist as soon as they can. So they should pay great attention in considering this option when many comorbidities arise in the same patients, for instance, or when some comorbidities are unusual for the age or for the gender of the patients. In particular, I would say that they should focus on the clinical investigation in terms of signs, symptoms that are more specifically related to Cushing syndrome, for instance, the moon phase, the facial plethora, the supraclavicular and dorsal fat pads, the abdominal or visceral obesity, the purple stria in the abdomen or in other part of the body, and also the proximal mass atrophy, as well as a relevant weight gain in few months regardless the effort to lose weight by the patients, or recent increase in blood pressure and blood glucose, some uncontrolled hypertension or diabetes, which occurred, for instance, in young age when you don't expect to have all these comorbidities, especially together, or regardless of multiple pharmacological therapy. Or again, some spontaneous skeletal fractures which occur in younger age than expected, or in men where it is less likely compared to women after postmenopause age. And other clinical manifestations like depression or psychosis, which can also suggest this kind of disease. So the role of the general practitioner, I think it's very important. And I've also to say that in the evaluation of these clinical manifestations, the general practitioners should also consider the other common conditions, clinical conditions, for instance, the metabolic syndrome, diabetes, the depression, or also the more common polycystic ovary syndrome in women, which may present some clinical features which are partially overlapping with those of Cushing syndrome, because they are also called pseudo-Cushing states, and may lead to unnecessary hormonal and biochemical evaluation. And this is not often very easy, especially for not experienced general practitioner. But this should be very important. Moreover, in order to fasten up the diagnostic workup, a standard tool of initial testing, for instance, the evaluation of circulating ACTH and cortisol levels, or the urinary free cortisol levels, which are usually necessary in more evaluation, collected in different days, should be required by the general practitioners as first-line screening for Cushing's syndrome in order to help a better identification of clinical candidates for this endocrinologic evaluation. Of course, not all general practitioners are ready and also sufficiently expert to do that, but this should be their role, actually very important.
And regarding this relationship between general practitioners and specialists, when should patients be referred to an endocrinologist?
Well, in general, the referral to endocrinologist is very crucial because it's important to provide a safe, correct, and complete diagnosis, and also rapid diagnosis in patients with Cushing's syndrome, and also ensure a prompt treatment for this severe disease and also for their complications. So, generally speaking, I think that general practitioners should refer to endocrinologists in patients with a moderate or high clinical suspicion for Cushing's syndrome, and if they are associated with at least one abnormal result in terms of biochemical parameter like urinary free cortisol levels, in order to allow endocrinologists to have some initial elements to consider in the diagnostic evaluation and so to avoid the diagnostic delays. However, patients with moderate or high clinical suspicion may be referred to endocrinologists even in the apparent absence of abnormal hormonal results, especially if the general practitioner is not experienced in the evaluation of hormone assay, as many different situations may lead to non-univocal results. For instance, errors in urinary collections, including incomplete collections, as well as improper sample storage and processing, are very common in endocrinological evaluation. But general practitioners may be not aware of these specific requirements for the hormone evaluation and therefore potentially underestimate their impact on the biochemical results. Therefore, beyond the required improvement in healthcare providers' awareness and knowledge on Cushing's syndrome, an early referral in case of moderate high clinical suspicion, I think, should be always considered by general practitioners, which become then mandatory and urgent when this situation is associated with some alteration in the hormone profile.
Well, thank you very much, Professor Pivanello, for all this clear information about Cushing's syndrome. As for us, dear listeners, we thank you for your time and we look forward to seeing you on our podcast channel for a future episode on Cushing's syndrome. See you soon.